Hi, guys. Welcome to another episode of House of Health podcast. Today, we're busting some more myths, and today's topic is back pain. I have two extremely talented individuals who happen to be close friends and allies in the medical field. And today, we'll be talking about back pain. I've got Rick Lovell here with me, who is a physiotherapist and has been in the game for a long period of time, working at the highest levels with athletes and professional footballers. And I've got Dr. Anita Raja here, who is the CEO of House of Health, who's been a GP for over a decade and deals with back pain problems. So I've got lots of questions coming in from yourselves, and we'll try and ask these questions to both of our guests. So Rick, quick introduction about yourself. What do you do? And tell us about yourself.
So I'm a physio by background, by training. I've been doing this for quite a while now, so nearly 17, 18 years. Background-wise, I've spent some time working in professional football, and over that 18-year period, I've worked with professional athletes, all rugby, most sports, athletics, still work with quite a few of those guys. Then also everyone else in the general population, so everyone from an elite performer to your grandma and everyone in between.
Great stuff. And Anita, just introduce yourself as well.
Yeah, so I'm Anita Raja. I am a GP and I have been a doctor for more than 10 years. I've not been a GP for 10 years though, so that was not quite the right introduction, but I have been a GP for a fair few years now. I'm very passionate about talking about, health awareness, because I feel that when it comes to health awareness, it's so important that the right people are giving you health advice. There's so many people out there that call themselves influencers on TikTok, on social media, and they're giving you all types of wrong advice. So it's really important that people like, Rick, like myself, take the stage and inform people in the right way, really.
Sure. So Rick, let's start with you. You've got a model of a spine here. So my first question is just generally, what causes back pain? What are the most common reasons why people present to you with back pain?
Probably the most common reasons are all boiled down to mechanical loading. So you will have diagnoses such as non-specific low back pain or insidious onset low back pain, or all these kind of terms that get thrown around, which are kind of loosely speaking terms that don't really describe why you've got the problem. So, mechanical low back pain is all your low back hurts, which the patient knew anyway. And then you get your non-specific is, well, we're not really sure how you did it because you didn't have a specific twinge or, ow, my back's gone. And so we don't know why you've done it. But if you really dive down into what's happening with people and the history and what they do in their day-to-day and their exercise or lack of exercise and various other factors, you can start to pin together or piece together why they've got the issue. So if we look at the majority of people that come into clinic, we see hundreds of people a week, and a good number of those are back pain related. Posture is a massive one nowadays. And, the majority of people now probably sit at a desk for work. And a good chunk of those people get in the car, drive to work, get to work, sit in the desk, get in the car, drive home, get home, sit on the sofa. Not everyone, of course, but quite a lot of people. And even the people that maybe do more exercise, do more activity and whatever else it may be, still spending half the day or more sat down. So that is a big component of it. And, prolonged sitting is not particularly good for us in terms of our spine and our health in general.
What recommendation would you give them, right? So if someone's got a desk job, 9 to 5, sitting all day, what should they do as part of their daily routine that would prevent them from having back pain?
So one of the interesting things we've got now compared to maybe 5-6 years ago is the amount of people that work from home, which gives a degree of flexibility. So one of the things we'll often say with our clients is set a reminder on your laptop, on your phone, or whatever it is, so you get like a message every hour or so. Stay up. And ideally, we will go through when we're treating someone, we do hands-on treatment, we'll do soft tissue release, we'll do joint manipulation, we'll do the strengthening, we'll do the rehab to help them improve strength and eliminate their pain. But then also it's like, well, how do we optimize you? How do we go further from here? So bear with me, I'm getting to your question. So we want everyone to be strength training. We want everyone to be deadlifting. We want everyone to be doing cat busting. We want everyone to be squatting. So they develop this long-term strength, resilience, muscle mass that not only helps with their back, but also their overall health and well-being long-term. So if we get people on board with that and we can get them doing kettlebell swings or even just things like banded deadlifts, very low cost, low level of, very easy to do, it will be get it from your desk. And ideally, we can do 20, 30, 40 kettlebell swings every hour. That will keep you feeling so much looser, and it builds strength. And you build massive volume through the day, through the week, and it makes a big, big difference long term. But even if someone doesn't know how to do that efficiently and effectively, like many things, doing it well is brilliant for you. Doing it badly is not so great for you and may well cause an injury. So it's about understanding where you are with that, much like the myth about deadlifts being bad for your back. Deadlifts are amazing for your back if you know how to do them properly. You're not so good when you don't. So for the other people, it's, can you just stand up? Can you stand? Can you rotate 10 times to each side? Can you side bend? Can you flex? Can you extend? Bend over, touch toes. Can you arch back? If you did 15, 20 reps of each of those, your back will feel loads better. Yeah. It's just movement. Joints are designed to be moved. So if we don't move them, they don't feel so great. It's when you think about how they work, it starts to make a bit more sense to why they feel a bit stiff and a bit grumbly if you sat down for 6, 7, 8 hours a day.
Yeah, well, that's a great thought. Anita, so a common misconception is when people present with back pain to GPs, the misconception is that they're just given painkillers. What is your take on that, and how do you assess someone with back pain? Do you just give them over-the-counter medications, NSAIDs, paracetamols? So just wanted to have your thoughts on that.
So in general practice, bear in mind, we just have 10 minutes to assess this patient. So 10 minutes from the minute they walk into the room, we take a brief history, we do an examination, give a diagnosis, and do the prescriptions. 10 minutes are not enough to diagnose the causes for back pain. That's the first thing I would like to see. But the rule of thumb in general practice is that if someone has had back pain for more than 6 weeks, then we class it as chronic. And at that point, we do sort of think, well, it's not work. So what is happening here? That's when we advise patients to do a self-referral to physio, which can take a fair few months before they actually get the appointment. Or if it's bad, where they have symptoms of nerve impingement. For instance, they say that they've got pain in their arm, which is sort of shooting down, or they've got pain in their leg, which is shooting down, which is really affecting their quality of life, their ability to remain into work for more than 6 weeks, then we may offer them an MRI scan, which looks at sort of anything sinister underlying. However, I agree with Rick, because, the way life has changed now is that most of us, and I say with conviction, most of us are now sitting at a desk and doing our jobs, which is not what we were designed for. I mean, human beings were not designed to sit on a chair in front of a desk, 12 hours. That's simply not what we were designed for. So that is a big factor. And I also see that with women, especially women who are going through the menopause, women who are struggling with weight gain, because around the time of menopause, you have an average weight gain of 6 kilograms. So imagine gaining weight on top of having this lifestyle where you're hardly moving. That is going to have a compounding effect on your muscles, on your back, and you understandably are in pain. I mean, for us, we advise over-the-counter medication because we worry about the misuse of opiates. But I wouldn't like to say that opiates don't help, because they do initially. I mean, medications like dihydrocodeine, diazepams, these are muscle relaxants. We don't ever prescribe them for more than 5 days. And the idea is that when we give you these medications, it's an analgesic, which means that you don't feel the pain. So you may move a bit better, because there is no such thing as resting your back. That's an obsolete concept.
So this was exactly a question that we had. Said that is bed rest the best remedy for back pain? So
I think Rick would be the right person to answer this question.
It would make sense, right? You've got pain, rest, no?
So it would, if you have a severe spinal injury, possibly, yes, there'll be a period of bed rest if you've got significant fractures or along those lines. Assuming you haven't, what we'll always say is rest from aggravating activities. So we see clients on all ends of the scale. So we've got our high-end athletes, we've got not high-end athletes, so they're down the other end of the scale. And there will always be rest from aggravating activity, and that's something different to every person. So if they say, oh, well, if I walk for an hour, my back's really sore, but if I walk for 15 minutes, I'm fine. You absolutely want to walk for 15 minutes.
Yeah.
Movement, some sort of movement is better than no movement. Bed rest is problematic in so many ways. The main one is if someone spends 4 or 5 days in bed, you will get a reduction in your muscle mass. Yeah, that's simple. Which now means not only do you have some back pain issues, you're now weaker than you were before. So you've got to you've got to improve just to get back to where you were before you had all the bed rest, and then kind of kick on from there. So non-aggravating activity is something we'd always advise. Now, if someone's like, it's really painful to bend over and pick things up all the time, we'll try and limit that. If you can walk, great. If it's painful when you walk, but you can do some stretching and mobility, great, let's do that. The thing is with back pain, it varies so much from person to person. So you could have 1,000 people who all say my lower back hurts, and they could all give you a slightly different reason or timing in terms of it hurts when I do this or it hurts when I do that. So when we see someone, it's always, what are your specific aggravating factors and how can we work around those? I think if you go with something generalized for anyone that may be watching or listening to the podcast, find the things you can do that allow you to move without making your symptoms worse. That's probably the biggest factor. And in terms of making your symptoms worse, specifically, it would be increase your pain partly during, but more so afterwards. If you have an increase in symptoms after you've done the thing or the next day, probably not advisable to keep doing that thing.
Yeah. Another question that we received, again, is it a myth or not? Lifting heavy objects always leads to back pain. What do you have to say about that?
Okay. So if you look at athletes are a good example. Bodybuilders, regular gym goers, they regularly lift really heavy things, and most of them don't have back pain.
And I think this comes down to the fact that proper technique is absolutely essential. If you're doing it the wrong way, and if you're loading your spine in the wrong way, you will end up having an injury.
Yes. You've also got your tolerance to the activity. So if you take a bodybuilder who trains at the gym all the time and is extremely strong and in very good shape, if you ask them to go run a marathon, they're probably going to get injured because they haven't developed tolerance to that activity. If you take someone who doesn't normally lift, and again, this is a great example of what we'll often get, where someone will come in, oh, my back's been really sore, it flared up over the weekend, what did you do? Oh, well, I did 8 hours of gardening Saturday and Sunday. What do you normally do? Great deal. What did you do Saturday and Sunday? I moved 3 tons of gravel, I dug out the beds, I pulled out loads of weeds and X, Y, and thinking, right, can you see the drastic change in activity here? Now that's potentially overloaded your back. Whereas if you take a landscaper who does that day in, day out, they tend not to have that issue if they do the exact same thing. So it's all about what your body is used to tolerating. And if you're doing something new, if you don't train and you want to train or you don't lift heavy and you'd like to start lifting heavy, it's just a gradual process of doing that. Just like if you're to train for a marathon and you don't normally run, you don't start out with 26 miles.
Yeah, you'll do that slowly. So Anita, this brings me on to another question. Again, there's a lot of misconception around spinal problems. Is surgery quite common? Is that the only treatment? At what point is it indicated? When do people start thinking about presenting themselves to hospital?
So it's a very good question you've asked me. So when I joined the NHS many years ago, so almost sort of 10 years ago, the first job I ever did was on a surgical unit, which was a spinal surgical unit. And I used to see lots and lots of patients come in for spinal surgery. But as time has gone on, we now know that there is not much evidence to support the fact that spinal surgery helped, unless, you've got a complete nerve compression, which is detrimental to limb, and you need to do surgery. So that's the last resort. Now, surgery, is very complex, spinal surgery particularly, and it leaves you with long-term side effects of surgery or the aftermath of surgery. This is why we try and do conservative management as long as we can with the help of people like Rick, because we want to preserve that muscle mass. We want to rehabilitate that spine. We want to get that movement back. And that can be done with physiotherapy and the right medication. You asked me about, medications earlier on. Non-steroidal anti-inflammatories are good.
What kind of medications do non-steroidal anti-inflammatories comprise of?
So ibuprofens, naproxens, nebulital, these are medications that we can give you. However, they cannot be given long-term because they affect the lining of your stomach, they can affect your heart, they can affect your kidneys. So we've got to be very cautious when we're taking them. There's a certain technique of taking them.
It's interesting you say that because I, in my practice, have seen people coming in with perforated gastric ulcers, taking NSAIDs for a very long period of time where people have not asked them to stop. And you ask them and they said, we've been taking this for 3 or 4 years. They end up with liver disease. They end up with kidney problems. It's because no one's asked them to stop. And because they do work, they are very good for your symptoms. But now more and more, the medical field is going away from prescribing NSAIDs. They called gastric ulcers, as I mentioned, other issues. Yeah, please carry on.
And my worry also is that, sometimes explaining how to take them, because we are prescribing naproxen because it's a prescription drug, and then they're taking ibuprofens on top. So, making sure that you tell them, please only take what I'm prescribing, take it with food, take it twice a day, don't take it for more than 2 weeks, and come back if you're no better. I think that follow-up appointment is key. And when it comes to medications like opiates, or benzodiazepines, these are medications that work as muscle relaxants. You can give them a very short course, but then there is the risk of dependence, and that is a worry and abuse, of course, of that medication. So it's not something that we prescribe long term. We have enough evidence now to suggest that when it comes to opiate use long term, they're as good as placebo, because your resistance and tolerance goes up, and you'll need a higher and longer and prolonged dosage of it, which is not good, and it affects your ability to be able to cope with life. I mean, you become dependent on it. You cannot think straight without it. And that's not what we want. You've come with back pain. We definitely don't want you to end up being a drug addict. So, I think it's very important that we have that right balance in prescribing the right medication, the right exercises, and nipping the bud.
Yeah. And what we often find is that as doctors, it's very easy for us and even the patients, they want a quick fix, right? Medications seems to be the quick fix. Physiotherapy almost feels like, oh, I have to exercise for this period of time. Rick, in your experience, how long do people need to see a physio for? Do they need to come have a course, or, what's your kind of practice?
So it's a very good question. It is the question we get asked a lot. So how many sessions do I need? And you'll get that question over the phone or via email. And without seeing someone, obviously, it's very hard to say. Now, there will be times, not always, where the duration that someone's had the issue for will be somewhat commensurate with how long it takes to fix it. Now, if someone's had back pain for 10 years, it does not mean it will take 10 years to fix it. But if someone has had back pain for 10 years, they're not going to be better next week. Now, I think on that is, you touched on earlier in terms of in your practice, and I think it's part of the standard guidelines, so back pain that's more than 6 weeks old is classed as chronic. Yeah. There's a lot of misinformation, misunderstanding, and then also just very varying schools of thought where people will happily argue about this over and over again in terms of what is and isn't pain. The standard definition that we see on our side is back pain that's been there for more than 3 months. And there's a very big movement towards, after 3 months, you have chronic pain. And the slight differentiation there is a belief or a suggestion that between 0 to 3 months, any kind of tissue damage will have healed. And if you're still in pain after 3 months, there is a pain modulation issue with the way your brain perceives the pain, and that's where you've got the pain. I could not disagree with that more, and I think it's complete nonsense. And I can say anecdotally, reflectively, because this is from my practice and the practice of my mentor and the practice of the guys who work with me now in our team, we can have someone who's had back pain take 15 years, we can fix them. And I don't say that in any way to sound any arrogance or anything like that. It's just, we've seen it, we do it quite regularly. But it's about understanding the nature of their pain and what is happening with it. So how many sessions will somebody need? So if someone comes in with long-term pain, they will have long-term compensations. They will have changed the way they move. They will be stiff. They will be restricting various muscles around the spine, the joints in around the spine. So without giving everyone an anatomy lesson, you have the vertebrae that stack one on top of each other with the discs in between. There are junctions or joints from one vertebrae to the one below it that form a joint. It's called a facet joint.
Just move this here, Rick, just so people can see the camera perfect.
Yeah. So the small joints on the side here, facet joints.
Yeah.
And they kind of create the hole that your nerve root will come out through.
Yeah.
Now, your facet joints are often the factors or the component that responds for a lot of back pain and pain that you feel from your back. You will often hear people talk about pulling their back or pulling a muscle in the back or tearing a muscle in the back. Anita, I'm sure you've probably had a few MRI reports back in your time. I've had thousands. Not once has it ever said evidence of a muscular tear in the back.
They just talk about spine and bones.
Yes. No, because it doesn't show it. As in, if there was one, the MRI would show the tear in the lumbar muscles. Never had it on a report.
No, really?
Ever. Now, what you will get, normally for most people, when their back locks up, or they've got that grumbling, like low back pain, or whatever it may be, assuming they've not got that rip-roaring peripheral pain that you will get with a disc prolapse, as in pain going down the leg, or arm, in the neck, it's inflammation or irritation of the small joints, the facet joints. And they, not only will they cause localized pain, they can refer pain all over the place. There's lots of studies being done. I'm not sure who volunteers for these. I think it's normally students who need the money, where they inject saline directly into the facet joint, and they will measure, where does it hurt now? And they're like, oh, this pain's coming all around my side, it's coming down my hips, coming down my leg. So any kind of irritation, inflammation, damage of those facet joints can cause all sorts of pain locally and into the hips, glutes, legs, and elsewhere. So that is what is going on with most people, one way or another, when they get their back pain. How long does it take to fix it? As you said, well, we've got to address the muscular issues because the muscles around the area will get tight and restricted as a result. We need to mobilize and manipulate the joints to restore normal joint function. That reduces pain. However, we've then still got muscles that have been very tight, very immobile, not working very effectively for quite a long period of time. So if they go back to activity or increase your activity, there's a good chance that back pain is going to come back. Then you've got to do the strength and you've got to do the rehabilitation. That normally starts with controlling lumbar and pelvic movement, restoring basic control of function in the area. And then we build that onto more sort of advanced, when I say advanced, I don't mean massively advanced, but things like lunges, split squats, deadlifts, hip hinges, educating people on how to move, how to bend, how to lift effectively, and while minimizing the risk of chronic injury. If we've got someone with a chronic injury, realistically, we're probably looking at, on average, probably 6 to 8 sessions to get them to a point where they're like, oh, actually, my movement feels really good and my pain's loads better. Then we can effectively strengthen. Because while we're in pain, muscles get inhibited and we can't effectively strengthen, which is why when people get given exercises, just exercises, they often don't see an improvement.
What's your take on the kind of usual practice where people are giving videos and said, off you go, these are your videos, sometimes patients not even seen. Yeah.
If it was that simple, we wouldn't have the issue we have with back pain.
Yeah.
And we wouldn't have this belief that chronic backs don't get better. And I think that is a common belief based on some of the limitations that we see in certain settings, and whether it is the NHS or not. And the NHS is an amazing service and there's no better place to be, I don't think, if you're really, really poorly. But due to the time constraints and the pressure constraints on it at the moment, and again, I don't work in there, so I can't give an accurate explanation. But what I am hearing and what I'm told is, it's often you get maybe 2 sessions, maybe 3 sessions, 3 to 4 weeks apart, and it's what is the problem? So back pain, here's a sheet of exercises.
That's
exactly what we were discussing earlier. Yeah.
So with that, if you've got a longer term history and you've got all of these movement compensations and you've got all of this joint stiffness, all of this muscular stiffness and tightness, and then you've got this weakness that affects your ability to control the mechanics, it's just not going to work.
Yeah.
It just isn't. Whereas if you have the time and the resources to tick all of the right boxes and address joint restriction, address muscle function, improve strength, improve mobility, re-educate the movement patterns, you should get a long-term solution. And then again, that doesn't fix everyone. I wouldn't pretend that we do fix everyone. However, with our background and our experience, we have a network of specialists that we can work with, where it may be that someone does need injection, they may need a nerve root injection or a facet joint injection, and that can matter to reduce the pain. Then in some instances, they get some improvement, but the pain comes back again. We've now identified, if the injection was effective for even a short period of time, for 4 or 5 weeks, this is the root of the pain. You can then have a procedure called resolysis or radiofrequency denervation, where they literally obliterate and burn off the portion of the nerve root that sends out the pain. And it's amazingly effective. And possibly, if that doesn't work, and it's very rare that doesn't, there may be a surgical aspect to it, where they need to decompress the foramen, where the nerve is coming out, or whether there is a disc issue. But I can quite confidently say, with enough time and enough resources, we expect like a drastic improvement. I'm talking 80, 90% in probably 90% of the backs that you see, if they have those resources. Now, there is an element of, if they have private insurance, it can work. If they have deep enough pockets, it can work that way. But unfortunately, I think with the way our current system is, if they're relying on the healthcare system as it is currently set up, those chronic backs often get referred into a class where it's, okay, you need to learn to manage your pain and pain management. And they don't really progress much further from that.
I couldn't agree more on that. Now, if coming down to, I'm sure there'll be lots of questions and comments from viewers about if they want to see either of you, their back pain, how do they get in touch? And is there any way where you guys work together, or is there a referral system where someone with back pain presents to yourself?
So I work from the House of Health. I work there 4 days a week, and the rest I still work for the NHS and hope to do so. because the NHS has given me a lot. And as Rick said, it's a phenomenal organization set up, healthcare service, which is great for people with cancers, long-term conditions. And, but when it comes to acute problems, I guess, you can always come and see me at the House of Health. I work there with a team of doctors. Rick and is partnering with us, House of Health, and we'd be working together. So, Rick, if they want to come and see you,
Rick, where's your practice? And you're in Birmingham. You've got multiple sites.
We'll be doing some work, obviously, from House of Health, as Anita just mentioned, which we're looking forward to. In terms of our business, Achieve Health, we've got multiple clinics. So we've got 4 clinics across sort of Birmingham and Solihull. I work from 2 of them. I've got a team that work with me, and they're great, they're brilliant guys. They're mostly passionate about what they do. And we're very big on training as well. So all of our guys, we do a lot of training every week. If people want to know more about us or would like to find an appointment, our website's a very easy way to book, which is achievehealth.uk.
Yeah, and we'll plug both websites at the end of this video, so you can always click. The links are also going to be there. And
I think it's also probably important to mention as well, and in terms of the crossover, that probably less so in the younger patients that we get, but the older, let's say old, my age and above, so once you're into your 40s and beyond that, there's more evidence now, and certainly something we've seen is it's the overall wellness of the person, it's the commitment back. That happens in men, but more so in women as well. Once you're on that menopausal stage, you get those significant hormone changes. There's definitely this massive benefit of this kind of cross-working between ourselves and maybe someone like Anita, who can overall hormone health and overall body function, because we've seen clients really struggled with various issues for years, and I don't want to digress, but especially things like frozen shoulder, fasciitis,
osteoporosis
in the female population. And when the testing has been done, see how low some of the hormone levels are in their estrogen in particular, and they have HRT, and 3 months later they're a different person in so many different levels. Their musculoskeletal pain can just decrease significantly. So there's so many different factors at play with kind of pain and injury.
Yeah.
And it's quite exciting to be able to work with and collaborate people that understand that and can help to kind of address the areas where we don't have the expertise and vice versa. I think that's quite exciting.
I think that's a really good point. Right, guys, that's all from this episode of House of Health Podcast. Thank you very much, Rick. Thank you, Anita. If you have back pain, 80% of people will suffer from it at some point in their lifetime. So it's a common condition. So if you have this symptom or anyone that you know has these symptoms, please get in touch with our experts, and I'm sure they'll be happy to help. We'll be back with another episode of House of Health Podcast. Thank you very much for listening, and thank you both for being here today. That's all.